All right. Well, welcome everyone. Joe's going to be speaking on challenging glaucomas and challenging patients. Dr. Joseph Sowka is an attending optometric physician at Center for Sight in Sarasota, Florida, which is a large medical surgical practice where he focuses on glaucoma management and neuro-ophthalmic disease. Joe is the resident education coordinator at Center for Sight and the Director of Optometric Business Development for USI. Joe was formerly professor of optometry at Nova Southeastern University College of Optometry for 28 years, where he served as chief of the Advanced Care Service, Director of Glaucoma Service, and the program coordinator and supervisor for the Ocular Disease Residency. Dr. Sowka is a founding member of both Optometric Glaucoma Society and Optometric Retina Society. He is also the founder and former chair of the Neuro-Ophthalmic Disorders and Optometrics Special Interest Group for the American Academy of Optometry. Dr. Sowka is a glaucoma diplomate of the American Academy of Optometry, and in 2021 and 2022, he was ranked the #4 optometrist in the U.S. by Newsweek magazine, America's Best Eye Doctors list. Joe is a colleague, friend, partner, and co-owner of Optometric Education Consultants. Joe, listen carefully here. The audience is going to give you that big, round, virtual applause. Please take the podium. It's all yours.
All right. Thank you, Greg. Thank you, everybody. Tonight's topic is challenging glaucoma, glaucomas and challenging patients. And it is my privilege and honor to be the one who is closing it out for 2022. And I'm also pleased to say I'm going to be opening it up for 2023. I think I'm going to have the first one. Now, what's challenging about it? Well, it could be the type of glaucoma that's a challenge, or maybe the type of patient that's a challenge. You know, it may be an atypical sort of patient. And one thing we don't talk about is managing glaucoma in the atypical population. Our typical population usually is the elderly, where they may have 15 or 20 some years of glaucoma management, but that isn't every type of patient. Now, these are my disclosures. I'm a consultant or on the Speakers Bureau for Santen and Bausch and Lomb. Got no financial interest in any of the disease products or instrumentation mentioned. All my disclosures have been mitigated, and as Greg said, I am a co-owner with him of Optometric Education Consultants, and it's our privilege to bring education to our colleagues. And this is a lecture that was created by myself, solely by myself, and will represent my experiences on the topic. Well, first one case is an 8-year-old Haitian female. She has blur at distance in her left eye when she had her first eye exam. I think she actually failed a school screening. And this was when I was at university. She came into our pediatrics department. Now, reported she was healthy, normal development, born in Haiti, no trauma. She had a maternal uncle with glaucoma, possibly diagnosed at age 40. But that was relatively sparse history. Now, when she comes into our pediatric department, she's 20/20 in the right eye, 20/60 in the left, best corrected. She's got a relative afferent pupillary defect in the left eye. Her pressure is 21 and 24, right and left eye respectively. Now, I will tell you that whenever I would see things like that from our pediatrics department, I always have a bit of, I don't want to say suspicions, but I always wondered what exactly how much trauma went into getting those pressures. Was this a very easy child to examine, or did they have to get out the Velcro straps and bite pads? I don't know how much trauma goes into that. But they noticed large cupping, and they're concerned about disc pallor in the left eye. So they referred the patient to me for evaluation of optic neuropathy. Now, before they referred the patient over and dismissed the patient from the pediatrics department, they said you should probably get an MRI. But just saying get an MRI does not mean anything is going to get done. You actually have to order the doggone test. Greg, that brings me polling question number 1. What is the most likely diagnosis? Brain tumor, open angle glaucoma, hereditary optic neuropathy, infectious optic neuropathy, infiltrative optic neuropathy, or some form of kitty glaucoma, as I like to call them. So you got, I'll actually step it back a little bit. An afferent defect, 20/60 vision, disc pallor in the left eye. So people are thinking, people responding, doing very well, actually.
I just launched the handout into the chat.
Thank you.
And then, Tom, I see your comment about, I think, the course notes link for tonight's course or the Sunday's night's lecture. Thanks.
I'm gonna end the poll. I'm gonna share the results. A lot of people are looking at it kind of spread across the board. And I think the first and foremost is when you got a child with reduced vision, an afferent defect, disc pallor, you got to think about some sinister things. One of them being, of course, possibility of a brain tumor. So differential diagnosis includes glaucoma, but specifically what type? Compressive tumor, hereditary neuropathy, infectious, infiltrative. All right, so this is when I see the patient, obviously the MRI is not performed. Nobody actually ordered the test. They just told the parent, you should probably get an MRI. You just can't walk into, to an imaging center and say, I'd like to have one of these. It has to be ordered. Now, it wasn't the easiest of exams, confrontation fields she didn't respond to. I couldn't perform them. Threshold perimetry, if I can't do confrontation fields, I'm not can do very well with threshold perimetry. OCT, no luck there either. Was just not really, how can you say, participating well in the examination. Now, I'm not going to tell you that the kid was hard to work with, but I can tell you right now that the priest and the exorcist probably had an easier go of it than I did, and during that examination. Now, this is what I came across, and this is what I see. And let's look at her optic nerves. A little bit of an anomalous nerve, fairly large cup, but fairly pink and perfused in the right eye. Left eye, it is not really pale. There's just no rim tissue. She's probably about 95 to 98% cupped. The pallor that you see there is scleral tissue, glial tissue. It is not neuroretinal rim. She has got really end-stage cupping in this eye. Now, when I examined her, pressure was 30 and 36 by my hand, average pachymetry, no pigment dispersion. Gonioscopically, there's some irregular pigmentation, but the angle was open. There are no developmental abnormalities. There's no trabecular dysgenesis. Leads us to a diagnosis of juvenile open angle glaucoma. And this is sort of this was her gonioscopy. And yes, she's open. There's some irregular pigmentation, but she was open to ciliary body. And you may ask, well, if this kid is so hard to work with, how did you get a pressure and how do you get a gonioscopy? Well, the answer was it was critically important and we just had to do it. And it wasn't a pretty exam, but we got through what we needed to do. So, Greg, that brings me to polling question number 2. What is the best therapy for this patient with juvenile open angle glaucoma? Is it SLT? Is it glaucoma surgery? Is it a prostaglandin analog? Is it a beta blocker? Is it a carbonic anhydrase inhibitor? Is it brimonidine or is it a tarsidil?
I just confirmed the link is to the Sunday handout. Thanks, Thomas, for bringing it. I reached out to our IT. We'll see if we get that resolved, but the handout is in the chat box. And at the 10 o'clock, we'll see if we can get that resolved by then.
I think you have a copy. You have a copy already, don't you, Greg, in your files of tonight?
Yeah, I've already uploaded it to the chat.
Oh, okay, thank you. And I have no bloody ideas is a choice. So we got a lot of people who are responding. So I'm going to, I think, end the poll and share the results. And a lot of people like the idea of SLT. Other people like glaucoma surgery. Some people like prostaglandin analogs. I see a bromonidine or two and a beta blocker in there. You know, some people say, I just have no bloody idea, and that's why I'm here. And that's certainly an acceptable answer. That's why you're here. You're here to learn. So let's talk about the kitty glaucomas, you know, pediatric glaucomas, or what I like to, I call them kitty glaucomas, childhood glaucomas. There's a lot that's not well understood by clinicians. So I'm going to share some pearls with you so that when you see these atypical type of patients, you know what to do. Now, the primary pediatric glaucomas, we got congenital, developmental, infantile. These are terms that are used pretty synonymously. Primary congenital or neonatal, that is, the pressure is actually elevated in utero. So that's going to be picked up anywhere between birth and 1 month of age. Infantile developmental, that's somewhere between 1 month and about 2 years of age. There is a late onset that comes on over age 2. But the key on these kids is they have a developmental anomaly called trabecular dysgenesis. They don't have a normal anterior chamber angle. And as they don't have an normal anterior chamber angle, they don't have a normal aqueous drainage system. Now, juvenile open angle glaucoma does not have any angle abnormalities that you can see clinically. So infantile, congenital, developmental glaucoma, this trabecular dysgenesis, aqueous is not really getting out of the eye very well. There just is really no developmental normal angle. So this is a maldevelopment of the meshwork, the iridotrabecular junction, but there's really no other major ocular abnormalities. There's really no angle recess. It's very flat. The iris flat, inserts flat or flush right at or anterior to the scleral spur. You can see here that it almost looks like angle closure. Well, it's very, very flat, and there's really no angle in there. And sometimes you can see some irregularity of the iris. And this is actually known, believe it or not, as a Loch Ness monster sign. Now, when children or infants have a developmental infantile or congenital glaucoma, they're very symptomatic. You got this triad of epiphora, photophobia, and blepharospasm. They're very, very cloudy corneas from edema. That edema and corneal clouding is very uncomfortable. That's why the kids get the epiphora, the photophobia, and they're blepharospastic. And the increased pressure will lead to tears in Descemet's membrane, which can be pretty irregular. They can horizontal, vertical. They're known as Hobbs striae. Now, this whole condition used to be called buphthalmus, and buphthalmus meant cow eye because they had very enlarged eyes, because the balloon, so to speak, has been overinflated by the intraocular pressure. They have very, very large corneas. The corneal diameter is usually well over 12 millimeters. And this is the things we can see in the infants with glaucoma, the very, very large cornea, the very prominent eyes, corneal edema, or the breaks in Descemet's membrane we see called Hobbs striae. That is a mechanical phenomenon from the increased intraocular pressure to very, very fragile plastic system. The Descemet's membrane is breaking, aqueous is flowing in, they become very, very edematous. Now, when dealing with suspected pediatric glaucoma, there's some management strategies that will be very helpful. Now, in an infant, if there's Descemet's tears, there's a enlarged cornea, they're photophobic, blepharospastic, they're tearing, you have corneal edema, that is an obvious referral right away to a pediatric glaucoma surgeon. And you need to have somebody who has experience with children. Now, if you're examining a youngster and you see a large CD ratio with normal intraocular pressure, my recommendation is always take photographs, do your imaging, your OCT, and give a copy to the parent. Same thing if the pressure is slightly elevated with a normal angle and normal disc, take photographs, take your imaging, OCT, give it to the parents, because this is something that they're going to want to have as the child goes forward, because they're now a pediatric glaucoma suspect. They're probably always going to be a glaucoma suspect. And this is a nice example. This was a 12-year-old that was in our pediatrics department, and I was asked to consult as to whether or not I thought a 12-year-old can do a visual field, which some can and some can't. I've got adults who can't do fields. And what we see here is a pretty asymmetric cup to disc ratio, probably about a 0.3 in one eye and probably about a 0.6 or 7 or 8 in the other eye. And the asymmetry was what was troubling the providers at that time. And take a look at it. That nerve looks absolutely fine to me. That nerve looks absolutely fine to me. And these are not magnification differences. This was the actual asymmetry in disc sizes. So when we did an optic nerve imaging, the kid had all the requisite 1.2 million axons that were needed. Everything was nerve fiber layer normal. So take pictures, give the imaging to the parent. This will always be a suspicious finding, but the kid is perfectly normal. So talking about juvenile open angle glaucoma, and I've seen a number of these patients. It's diagnosed in childhood, and the pressure is present by about the 16th birthday, somewhere between 3 years and 16 years when the IOP seems to develop. Now, when looking at the literature, I get a little uncomfortable with various studies talking about juvenile glaucoma up to age 40 or 45. I'm not really especially comfortable using that term, first diagnosis in adulthood, unless there is severe damage at the time of diagnosis. So I like to use this diagnosis of JOAG if the patient is diagnosed under the age of 18. Now, as I said, the literature, it goes up to about 40 or 45. I'm not sure I comfortably agree with all that. It is a more aggressive course than primary open angle glaucoma. And it's got a normal anterior segment. The cornea is fine. There's no ruptures and decimates. The angle is fine. But it's got a very strong hereditary component. This was actually the first glaucoma that was genetically mapped, and it seemed to be autosomal dominant. Now, this is one of those rare situations where I will take an adult. This is Edna. She's age 37. And I could say this is a person who probably has, even though we're diagnosing at age 37, juvenile onset glaucoma, because she's 98% cupped in each eye. She's at 10-degree fields. I know that this just didn't happen. Now, I'm not going to take a 37-year-old who's got 28 pressure and a little bit of a nasal step and a small notch in the neuroretinal rim and call that juvenile glaucoma. I'm going to call that primary open angle glaucoma. But when I see end-stage disease at this age, I know that's been there for a number of years. So I know that this is really probably a juvenile onset. Now, the meshwork is somewhat immature. It doesn't process aqueous well, but gonioscopically, it looks normal. And the biggest pearl I'm going to give you is this when dealing with kids. There's no normal tension juvenile open angle glaucoma patients. The IOP is always going to be high. And it's not going to be equivocal. You're going to see 30s and 40s. So if you see a suspicious looking optic nerve in a child, and the intraocular pressure is normal, you're more likely than not dealing with a physiological aberration. It's physiological, it is not glaucoma. There is no normal tension juvenile glaucomas. It's always going to be high, and it's going to be significantly high. Nice example, 13-year-old IOP is 28 and 43 with an afferent defect. You can see we still have a good-looking nerve and visual field in the right eye. She is cupped to about 85 to 90% with pretty significant reduction in visual field. And this is very typical of the cases of juvenile glaucoma that I've encountered. Now, interestingly, the first young woman that I had, she was 8 years old when I diagnosed her. I managed her. She ultimately ended up with surgery. And then she was, for a period of years, she was lost to follow-up. Interestingly, about 4 years later, I get another referral from the pediatrics department of a 10-year-old boy with pressure in the 30s. Again, I am always a little suspicious. So we examined him, and yes, his pressure was in the 30s. And as I walked into the room, the boy's father looked familiar. I knew I'd seen him before. He said, "Hey, how you doing?" That was his sister. It was now I'm seeing her brother with juvenile glaucoma. So basically everybody, all the kids in the family had the disease. Now, there are other pediatric glaucomas. You can have glaucoma associated with congenital cataract surgery, aphakic, pseudophakic, pediatric aphakic. It is a lifelong risk for developing glaucoma. So if you have a child who is aphakic or pseudophakic, had lens removed in childhood, they are at lifelong risk of developing glaucoma. And the mechanism, we don't really know. Pediatric aphakic glaucoma, we don't really know what the mechanism is. Gonio may show a blockage of the meshwork, because of a reposition of the iris against the meshwork. Vitreous prolapse may block the meshwork. Vitreous prolapse may lead to pupil block. We just don't really know the mechanism for sure, but it is a lifelong risk. You have glaucoma associated with systemic diseases or syndromes, such as Sturge-Weber disease, with elevated episcleral venous pressure. There can be non-acquired ocular anomalies, such as Axenfeld syndrome, or other acquired conditions from trauma, inflammation, episcleral venous pressure elevation, tumors, pupil block, subluxation. So there are a lot of secondary potential causes of pediatric glaucomas. Now, management in children. Primary infantile developmental juvenile glaucoma, that is a surgical disease. In fact, in the state of Florida, it's actually in our Practice Act that we cannot manage patients with infantile or congenital glaucoma because they don't want anybody to be forced gumping their way through medically with what is a surgical disease. This is treated with goniotomy or trabeculotomy, sometimes trabeculectomy, sometimes tube, but usually goniotomy or trabeculotomy. Medical therapy for infantile glaucoma is not appropriate. It can be used secondarily or adjunctively, but they first need surgery. Now, juvenile glaucoma, aphakic, secondary glaucomas in kids, medicine or surgery will be determined on a case-by-case basis. Now, talking about the procedures, goniotomy is an external, where they'll actually rupture through the angle through Schlemm's canal and basically wrench this probe, trying to open up Schlemm's canal and an area of trabecular meshwork, because it's a trabeculotomy. Goniotomy is using a goniotomy knife to cut through the trabecular meshwork, to cut through the iris tissue to open up Schlemm's canal so aqueous can drain out. Now, goniotomy has been used for kids for a long time. It was never really used in adults. It is making a comeback. In fact, it is one of the very common procedures done today. Now, goniotomy has a high degree of failure, so it can fail in kids. And the reason is they're actually just cutting this area open, which leads to the potential of it healing and closing up. Now we have the Cahook dual blade. I'm sure you've all heard of that, or many people have heard of the Cahook dual blade. That's actually a modified goniotomy that is being used more commonly. And it's got this dual blade. And what it does is it actually will remove sections of trabecular meshwork, whereas a goniotomy would normally just cut this area open. This actually scoops it out. And there's a far, far less likelihood that that tissue is going to seal up and close and heal due to inflammation. In fact, this device was actually developed to get trabecular meshwork for studies, for samples. But now it's being used very common and clinically. So goniotomy is making a comeback. And I can say that goniotomy is no longer just for kids. I think that brings me to polling question number 3, Greg. And it's probably very close to what I had earlier. Which is the best topical medication to start in a 10-year-old child with juvenile open-angle glaucoma? PGA, brimonidine, beta blocker, CAI, rho kinase inhibitor, miotic, or I've got no bloody idea, that's why I'm here. Greg, anything in the chat I should be aware of, or any comments you'd like to make?
No comments, and the chat box is quiet tonight. Just crickets in the chat box. I do see a lot of the surgeon in my practice. He does a lot of Cahook dual blades. I see he's been doing it for 2 or 3 years. A lot of my glaucoma patients that have cataract surgery, he'll do it at the time of cataract surgery.
But interestingly, unlike a device that's being implanted, this is a technique that is done with an FDA-approved device. It doesn't have to be done at time of cataract surgery. But it does improve, or it does enhance what was originally done with goniotomy. All right, got a lot of people in here, so I'm going to end the poll and going to share the results. A lot of people want to go with prostaglandin analogs. Some people like an alpha adrenergic agonist, beta blocker, CA is down there. Rho kinase and miotic, not very popular. And some people say, I've got no idea, that's why I'm here. All right, let's talk about medical management in children. All right, this is the literature, and this is also my experience. It does support this. Topical beta blockers are actually pretty safe and effective in children. In fact, they tend to tolerate it better than adults. It's really a very, very good option. And a lot of people want to go to prostaglandin analog because we're accustomed to the efficacy and the safety of prostaglandin analogs. The only thing is, we just can't look at kids as being mini adults. Now, prostaglandins are safe and they are well tolerated, but they just don't work. And I've seen a lot of this in the literature, and I've proved it myself to myself. I've tried it in a number of kids, and it just doesn't work. It usually is better for older children with juvenile open-angle glaucoma. In fact, if you want to know what my criteria is, puberty. Once they've gone through puberty, I will consider it. Now, it probably has nothing to do with hormones. We don't know why. Maybe whatever it is that prostaglandins do, the patient needs time to acquire whatever dysfunction. Topical carbonic anhydrase inhibitors are safe and effective, probably better than in adults. In fact, topical carbonic anhydrase inhibitors are the best options. Brimonidine does work, but it crosses the blood-brain barrier, and the adverse effects are just really not acceptable. This actually has induced coma in children. About the cutoff is age 8. Under age 8, you don't want to use brimonidine. Above age 8 to puberty, it's very, in my opinion, risky. I usually stay away from it. I usually only use brimonidine if they're post-pubescent. And rho kinase inhibitor, notarsodil, we don't really know. It hasn't been out there that long. One study showed a modest efficacy, about a 15% decrease in IOP. They don't really have any information about safety, and in this one study, about 82% stopped using the medicine due to lack of efficacy or side effects of corneal edema or hyperemia. So my summary algorithm, when I have to use pressure reduction in children, I always start with a topical carbonic anhydrase inhibitor. Then, if necessary, I will add a beta blocker. Obviously, the combination works out very, very well. Most of the kids end up on a generic COSAP. PGA in select cases, if they're older, if they're 15, 16 or above, I will try it. But, you can always try it, but don't be surprised if it doesn't work. It just tends not to work. Don't use alpha again. In children, it just really isn't safe. And the tarsal, I've got a question mark because, it's too new and we just don't know. So understanding pediatric glaucoma, the primary infantile developmental congenital, they have the abnormal angle. They don't have a normal drainage angle. That is the genesis or trabecular genesis of everything that goes wrong. They end up with enlarged globes, corneal edema. It's very early onset, and they're very symptomatic. Now, open angle, juvenile open angles, or juvenile secondary glaucomas, the angle's obviously normal. They've got a normal axial length. The cornea is clear. It can come on later. The cornea is normal size, and they tend to be asymptomatic. Now, I really liked this classification scheme, and this is from Peter Chang, a pediatric glaucoma specialist out of Bascom Palmer. Really, really great, great clinician, very nice person. So you start off with, is the pressure over 21? Is there asymmetry in cupping? Is there rim thinning? Is there a large CD ratio? Is there corneal abnormalities? Is there a big myopic shift? Is there a visual field defect? If you got, if you don't have two or more of the above, it's just a glaucoma. It becomes a glaucoma suspect. Now, if you've got more than two of these, congenital eye abnormalities or systemic syndromes, yes. Is there systemic involvement? Yes. All right, this is a glaucoma associated with a non-acquired systemic disease or syndrome. Now, if there's no systemic involvement, is it diagnosed after congenital cataract surgery? The answer is yes. They've got pediatric aphakic glaucoma. No, they have glaucoma associated with other non-acquired ocular abnormalities such as Axenfeld syndrome. There's no systemic abnormalities. They have a history of trauma, steroid use, uveitis. Well, this glaucoma is secondary. If they're ophthalmic, yes, they have a primary congenital neonatal development of glaucoma. And if the answer is no, then they have juvenile open-angle glaucoma. So I think that this flow chart that Peter Chang developed and laid out is, I think, very, very strong in helping us understand and follow these kids who are glaucoma suspects. Greg, anything in the chat room? Would you have anything to add?
Nothing in the chat box. Still crickets there, and
Okay.
nothing to add.
Is anybody out there? Okay. 26-year-old female. She's one of my optometry students. She comes into school and she's using Lumigan. Her pressure is 18 on a prostaglandin, but she tells me her pressure previously had been in the 40s. Now her nerves, fields, OCT, all normal, but she's got transillumination defects, peripheral spindles, and you can see this really, really dark pigmentation consistent with pigment dispersion syndrome. If this were three-dimensional, the iris would be bulging backward. And she has comes in with a treated pigment dispersion syndrome. And, she did pretty well for a couple of years, and then she became pregnant. So that brings me to polling question number 4. What do we do? What's the best option for this patient? She is now pregnant. Do we continue Lumigan? Switch Lumigan to Timolol? Stop Lumigan and see what happens? Switch Lumigan to Vermonidine? Perform SLT? Or I've got no bloody idea. That's why I'm here. Okay, so people are rolling in with their answers. Looks like we're doing well. Anything that you want to comment on, Greg?
No, everything's, good so far. You're covering it well. No comments.
All right.
Kind of interesting to see where the audience goes with this polling question.
So what's the best option? All right, I think I'll probably end the poll and share the results. People want to continue Lumigan, switch Lumigan to Timolol, stop Lumigan, see what happens, switch Lumigan to Vermonidine, do an SLT, or I've got no idea. Okay, excellent. Well, I will say we did stop the Lumigan, and the pressure did go up significantly. But if you don't know, you're not alone. Glaucoma in pregnancy. It's there's very few people have a tactical precedent here. In a survey, only 25% of ophthalmologists had any experience at all treating pregnant glaucoma patients, and of these, the majority continued the treatment, and the rest observed without treatment. Now, when asked what they would currently do, about a third said they didn't really know. I guess if you have a pressure in the low to mid 20s, that's one thing, but if you got a pressure in the low to mid 40s, that would be something different. So very little is known regarding the teratogenic effects of the glaucoma medicine, but the risk of giving ophthalmic drugs to pregnant women really does appear low. Now, Greg, you may want to add things in here because I know you talked about this extensively with Tracy Offredall. But we got our classes, class A, B, C, D, and X. So class A has been proven safe in human studies. B indicates presumed safety based upon animal studies. C indicates uncertain safety, but with adverse effects in animal studies, but not human studies. D medicines are considered unsafe, and X is a high lack of safety. Greg, is there anything you want to mention or talk about in terms of the drug classifications? Is this still in vogue, or have they changed things a bit?
Yeah, I forget the year that it came into play. It was like 2015. If you look at the package inserts, if the drug was approved before 2015, you'll still see kind of A, B, C, D, or X classification. Anything that's after that, like Xiidra that has come out, or some of the newer medications like Isuvis, they're going to have, they're not going to have the A, B, C, D. There's going to be, categories of, pregnancy, risk. It's actually kind of spelled out in a paragraph form. It doesn't have a nice, I liked A, B, C, D, X, X sounded bad, D we stayed away from. Really the safety area was A and B, but then they did expand it out more than just A, B, C, D, and X. They did, the risk for pregnancy, they did risk in breastfeeding, and then the reproductive system was the other one. So the new classification is a little bit more robust. I do kind of like when they use them both because it does give me that A, B, C, D, X, but any new medication comes out in the package insert doesn't have that.
Well, prostaglandins are class C. Most everything is a class C, to be honest with you. But these are class C because there are adverse effects in animal studies. But there's really no reports of human fetal effects used as a class of medicine. But most people consider prostaglandins ill-advised in all stages of pregnancy, mostly due to the fact they can cross the blood placental barrier. And they're actually known to, or be involved in stimulating uterine contraction. And exogenously applied prostaglandins are used in cervical ripening and labor induction. So there exists the theoretical possibility of labor induction, but that has never really been shown in any sort of report, but is a theoretical issue. So it may induce labor, but it's not been demonstrated. One small study looked at latanoprost exposure during pregnancy, saw no ill effects to the neonate in 9 cases. One patient did suffer a miscarriage, but it was not thought to be due to the prostaglandin. And of course, you don't have large studies here. You have very small case series and reports because glaucoma is a disease that typically occurs beyond childbearing ages. Beta blockers are class C. There's very little literature regarding fetal adverse effects of the topical beta blockers. One report had a 21-year-old fetus undergoing bradycardia and arrhythmia because of the mother's use of timolol. There are numerous cases where timolol has been used safely in pregnancy, and I can tell you, OBGYNs do not hesitate to use oral beta blockers for hypertension in pregnancy. There's more concern with topical beta blockers in nursing than there is in pregnancy. Timolol has been detected in breast milk at higher concentrations than in plasma, but still it's 1/80th of the cardiac effective dose. And the Academy of Pediatric has approved topical beta blockers for use in breastfeeding. So beta blockers should probably be avoided early in pregnancy and used only later in pregnancy. And the fetus and newborn really have to be monitored very closely for signs of apnea and bradycardia. But again, the Academy of Pediatrics does support its use in breastfeeding. The safest one we seem to have is brimonidine. It's class B medicine because there's no harmful effects in animal studies. It is one of the safer medicines to use during pregnancy. It may cross the placental barrier, but it's not really clear if it's secreted in breast milk. But caution should be used in breastfeeding patients. It's generally the first-line drug in first, second, early third trimester. Late in the third trimester, brimonidine usually should be discontinued because it can induce central nervous system depression in newborns. In that case, topical carbonic anhydrase inhibitors may be a little bit more optimal. Oral CAIs are class C. Acetazolamide is extremely low in infants' plasma level after breastfeeding. It appears safe in breastfeeding. In fact, the Academy of Pediatrics approves acetazolamide for breastfeeding. There are reports of fetal disorders from use in pregnancy, and they should be avoided during pregnancy, though. Topical CAIs, there's really no reported cases of fetal adverse effects, and really no reported case of successful use of topical CAIs in pregnancy. It has been reported to cause of metabolic acidosis in a 5-day-old male. That's one case. There may be some danger in the use in breastfeeding, but it is approved by the Academy of Pediatrics for breastfeeding. Cosapt is also a class C because of the beta blocker. Rho kinase inhibitors, notarsadil, the pregnancy warning, there's no recommendation. The manufacturer makes no recommendation regarding use during pregnancy. The FDA category is not assigned. Risk summary, there's no available data for this drug in pregnant women. So we can't make a drug-related risk. We just don't know.
Joe, I'll make a comment here if you go back.
Sure.
So the Rho kinase inhibitors, you can see there's not going to be an A, B, C, D, or X category on this because this is one of those medications that came out after 2015, and they don't use, if you want to say, that older classification. And as Joe mentioned, you're going to see most of the drugs that are out there be deemed category C because you're not going to do a human study on patients that are pregnant. So the comment, where a lot of this data comes from, the risk to the fetus, are from those patients that, didn't know that they were pregnant, right? And we all have seen those TV shows where, the person is walking, through some store and, all of a sudden they go into labor and they had no idea that they were pregnant for the last 9 months, right? We've all kind of, seen those kind of, amazing stories that are out there. Where a lot of this data comes from is from those patients that did not realize that they were pregnant, took medications over that course of that period. So the reason why I'm going into this kind of lengthy discussion is if you ever have a patient that has happened to, and you think that there's an adverse event, please contact the company and report it, because they will take it seriously. And that's how a lot of things are discovered. That's why when medicines reach the market and they do a study and they're not on pregnant patients, but then the adverse events, whether they're pregnant or not, please report those, because that's how we can build that list. But all of them are going to be pretty much C or nothing to report, because it's not right to do studies in pregnant patients. How we get that data are those patients that are using the medication, didn't realize that they were pregnant, and now they become, in a sense, an N to see if they do get any adverse events. So, but again, the Tarsadil is not going to be classified because it's after that 2015.
Excellent points, Greg. So our summary, prostaglandins, not in pregnancy, but breastfeeding, it seems okay. Beta blockers can be used in pregnancy. Breastfeeding is a little bit dicey. Although the Academy of Pediatrics does support it. Cosapt, it's one to be used with caution. Bromine is one of the safer medicines for pregnancy. So pregnancy, yes. Breastfeeding, most likely, no. Oral CAIs, pregnancy, no. Breastfeeding, yes. Topical CAIs, pregnancy, maybe. Breastfeeding, no. And rho kinase inhibitors are just generally unknown. So summary algorithm, they're pregnant. Alpha-Gen is a very safe medicine. Beta blocker, topical CAI can be used. They deliver now, they're breastfeeding. Probably stop all the above and you can go to a PGA. And beta blockers and carbonic anhydrase inhibitors are probably reasonable at this point too. Now, glaucoma surgery and pregnancy. Surgery can be performed with caution, second and third trimesters, but understand anesthetics, sedatives, antimetabolites, they have potential risk for the fetus. We just don't know exactly what they are. SLT seems to be an alternative treatment that can be performed at really all stages and all trimesters. So what happened with this young woman that I had as a patient and student? Well, we do know IOP does drop naturally in pregnancy, so we stopped the Lumigan to see what happened, and her pressure rose up into the high 30s. So she underwent SLT, her pressure dropped into the low 20s. That was fine for a while, and Lumigan was restarted following pregnancy and breastfeeding, and she did fine. So these are challenging patients because they're ones we don't have a lot of tactical precedent on. These are people, children, which can be very challenging to diagnose and treat, and glaucoma in pregnancy because it's just not a common situation. So they're challenging patients or they're atypical patients. And these patients can be challenging for any number of reasons. I'm going to move on and talk about this patient. He's a 31-year-old male whose medical history is unremarkable. His grandfather maybe had glaucoma, but that is somewhat controversial. His pressure on multiple times, he's 32 and 30. Pachymetry is average, gonioscopy is open, so a body, no abnormalities, and he looks like this. And we can see his optic nerves, and his optic nerves are very robust. He's got moderate cupping of a 40 to 45%, no notches in neuroretinal rim, no nerve fiber layer defects, no parapapillary atrophy, visual fields, and nerve fiber layer analysis. He's perfectly fine. So the diagnosis in this case is really pretty straightforward. It's not a challenging diagnosis. It is a patient with ocular hypertension. But where does it become somewhat more challenging? Maybe we can launch the next polling question, Greg. What is the best course of action for this patient? He is 31 years old. He is ocular hypertensive. His pressure is in the low 30s with average pachymetry. We want serial observation without ILP reduction. We want therapeutic pressure reduction, or do you want to do something else? And you can put that in the chat room. And that's just a picture of me and my dog.
So a question rolled in, it says, is tropicamide class C, do you avoid dilating pregnant women?
I do not avoid dilating in pregnancy. I explain the low risk, and I go ahead. I use phenylephrine, and I will use tropicamide. You're talking very, very low exposure because it's not not using it chronically. Greg, what are your thoughts?
Yeah, they're both, phenylephrine and tropicamide are both category C, using the kind of the older classification, which we all kind of understand, those who grew up on that system. They're labeled category C because there's really no human studies that are out there on them. So they just get thrown into there. So they can't say B, they can't say A on them. So there's no way to saying, yes, there's risk, or no, there's not risk. But then to answer the second part of the question, I do dilate. Typically, I pick one or the other. Usually just pick tropicamide 0.5% if I need to dilate someone that's pregnant.
All right, so let me end the poll and share the results. More people are happy to follow without pressure reduction, and the rest want to lower the pressure to treat him somehow. So, Greg, what are your thoughts here? I'm gonna let you opine. 31 years old, questionable history of glaucoma, pressure in the 30s, average pachymetry. There are his nerves, and there's his field.
Yeah, based on all that, I would observe. I mean, the field looks good. Looking at this looks like a GDX, looking like the T-SNP looks symmetric, maybe on that superior part, maybe looks really like pushed down, but it looks symmetric as if there's not a problem. Observation at this point would be my treatment.
Excellent. There are a lot of things that make this challenging, and particularly his age. You can make a lot of arguments here to treat or observe. What are the long-term implications? One argument can be made that, well, his pressure is in the 30s. He's only 31 years old. He has got a long time to get into trouble. He's going to have a predictably long lifespan. And if he starts to lose ground now, there's more likelihood that he is going to become visually disabled, and we should treat early. A converse argument might be, well, this is a person who is young, who's got a very healthy vascular system, and may be able to tolerate elevated intraocular pressure for an unknown number of years. And if we start him now, he might have 17 or more years of unnecessary treatment. Also, the sooner that you start treating a person, the less likely or sooner you can stem the potential vision loss. The argument is also the earlier you start treating somebody, the longer you have to have failure. And eventually everything is going to fail. You're going to have
Joe, what was the race
of medicines. He was African American.
Okay.
So these are situations where eventually the medicines can burn out, tachyphylaxis. You can give them ocular surface disease, burn out their goblet cells. This is not an easy one to decide what is the right option. Now, I actually presented this case. So I had two internationally renowned glaucoma specialists on the panel. One, Steve Getty, and the other, Rich Parrish, out of Bascom Palmer. And interestingly, One said I would absolutely treat, and the other said I would absolutely not treat them. So even people who are, in the glaucoma congenital don't know what to do in patients like this. Ultimately, what happened was we had a discussion. We talked about risk and benefits. He understood, and he elected to be treated. So I treated him with a prostaglandin analog. One prostaglandin analog reduced his intraocular pressure by about 50%. It was covered by insurance. It was well tolerated. And I followed him for, probably well over 20 years. And really nothing happened. He was a great glaucoma patient. He used his medicine. Photos unchanged, OCT unchanged, visual fields unchanged. Now, I could also argue if I did nothing, he may not have changed at all either. We just don't know. But this is a challenging patient. Diagnosis is pretty straightforward, but what is the best option? It's not really known. Like, all I can say is, after discussion, we did lower his pressure. He tolerated it very well. And over the course of 20 some years, showed no change at all. Greg, if we did nothing, you may have been right. He may have shown no change either, but we just don't know. Comments?
Question came in, direct message. What is the patient's BMI?
BMI, he was not obese. He was not even overweight. I would put him at normal to me, maybe just getting close to overweight. He was very normal.
Any family
Anything
history?
else? Maybe grandfather had glaucoma, but he really wasn't sure.
Yeah. I mean, yeah, it's a tough one, if you're going to follow it based on the race, you're going to follow it pretty closely. I probably follow it very closely in the first few years, because if they do get developed, you want to try and figure out if it's, fast progressing, slow progressing. But barring any secondary, really what you didn't mention anything about pseudoexfoliation or pigmentary, he's running a high pressure, doesn't really have any comorbidities. You can talk yourself in and out of which way to go, depending on what you want to do, right? You can talk yourself into treating it, but we do know that these topical medications do beat the hell out of the ocular surface. We see it all the time. So, who knows what we do for, 40 years worth of dumping chemicals on that front surface. So, but great case.
Well, here's an interesting case, and if you can follow along and figure this out, you really do know glaucoma.
Hold on one second, Joe. There's a couple rolled in here. Direct message is one. Would you have would you have added another medication the patient did not have an adequate if patient did not have an adequate intraocular reduction? Okay. So would you have added a second med?
I probably wouldn't, unless the prostaglandin didn't really work at all. I mean, if we went from 32 to 22 in the face of everything, I probably would have just watched that. If the pressure went from 32 to 28 or 29, I probably would have used another medicine. But if I got from 32 down to 22, I would have stood on that.
And then how about a non-preserved prostaglandin due to long-term ocular surface disease?
I think that's an excellent choice.
And I'm going to make a comment on that too. You got to remember that, when you say non-preserved prostaglandin, don't forget that it's a prostaglandin analog. I agree. Go non-preserved if the insurance will cover it. You're at least removing one of the toxins, right? The preservative. We know that BAK, and that came out of the ocular or the DO study, that the taking away the preservatives, especially BAK and artificial tears, was great for the ocular surface just by getting rid of that nasty preservative. It does beat up the ocular surface. That's in artificial tears, where the tear is, gentle, but the BAK was the monster. Think about prostaglandin analog / preservative. You're taking away one of the monsters, the preservative, but you still have a prostaglandin, which is a mediator of inflammation, right? So I agree, going to non-preserved does help out, but you still got a prostaglandin on board there. So just remember that.
Well,
That's
here's
my
a
comments.
patient. Anything else?
Nope, that's my comments.
Okay. He's a 40-year-old asymptomatic patient who came in for just a routine eye exam. He was known to have constricted visual fields on confrontation. He's a very high myope. He's a -17 with some cylinder, -18 with some cylinder. His pressure is 42, and his pachymetry is pretty average. Now, going biomicroscopically, he's got moderate central depth, but somewhat shallow peripheral iris. Maybe a little iris Bombay, I would say. So this makes it a little bit challenging. First off, he's 40 years old. He's a very, very high myope, and his pressure is relatively elevated. And what next? Gonioscopy. He's got anterior TM in one quadrant, left eye only. The rest of his angles are completely closed. He has a little bit of iridodenesis. The iris is a little tremulous, and he looks like this. What's wrong with this picture? You can put this in the chat. I'm going to go back a little bit. 40 years old, essentially a spherical equivalent of about -18 and change. Pressure's 42, and it appears as though he's got a closed angle. So we see what we're looking at here. There's something wrong with this picture. There's something wrong here. And what's wrong here is the key to the diagnosis. So what is
We
wrong
have a
in here?
question, Joe, that came
Yeah.
in too while they're waiting for the answers to roll into the chat box.
Mhm.
It says, if the patient is very nearsighted and has lattice, don't we want the pressure to be a little bit high so that it is less likely to detach?
I don't know it's an interesting thought. I don't know that I've heard anything about that or any sort of support. I'm going to say I'd be dubious about that.
Yeah,
But is anybody seeing anything wrong here, though?
The only time I've seen where you might want the pressure to be high with regarding the retina potentially could be with someone with diabetes or diabetic retinopathy to help stop the leakage. But I have not seen or spoken to a retinologist where, the longer eye or the lattice eye, it's going to be kind of where it's located, the lattice, whether it's inside the vitreous space or outside of it. If it's inside of it, there's a higher risk no matter what the pressure is that it's going to detach. So I would not go down that thinking, I guess, that a higher pressure. So all right, now they're starting to roll in, Joe.
Somebody direct message cupping. It is end stage cupping. Is probably about 90% cupped. Distended retinal veins. Okay, that's a good thought, Peter. AV ratio, good thought. Stephen mentions atypical to have closed angle and a high myope. That is correct. But the answer is actually in the picture here. The diagnosis is actually in the picture. And it's not what's in the picture, it's what's not in the picture. Yes, Thomas, a lack of myopia. There's nothing myopic about these nerves. If you've ever seen an 18 diopter myope, you should see somebody who looks very, very staphylomatous, and that is not here. And when I saw that undilated, I knew what my diagnosis was. A little sclerocrescent, but not myopic, no staphyloma. And look, biomicroscopically, the lens was kind of clearing the plane in the pupil. Diagnosis, he actually had phacomorphic glaucoma. This patient had microspherophakia. He's got a small, and this is not him, this is another patient. He's got a small round lens that caused pupil block and angle closure. Phacomorphic. Phaco's lens, morph shape, the shape of the lens. Usually this happens, and this is actually the most phacomorphic is the most common lens-induced glaucoma out there. Usually you have a mature cataract and the lens becomes thickened and it causes a pupil block. But here he has a clear lens. He's got microspherophakia. He's got a small round lens causing pupil block and is causing the myopia. Confirmatory findings on A scan, his axial length was about 24 millimeters. It's kind of short for an 18 diopter myopic eye. Eh? That's actually a little hyperopic. So this person, his glaucoma and his myopia has all been caused by this anomaly called microspherophakia. Small round lens, high myopia, pupil block.
Just for comment, Joe, just in case people don't do a lot of A scans, axial lengths. In my mind, I have 23.5 as by kind of being the average. I'm not sure what the, what you would use as average, but say 23.5, 24 is average. So that's just kind of a normal length eye is what Joe is saying there. And, if we remember, for every millimeter, you get 3 diopters. So you would think that this patient would be like a 29 axial length if they were from like a staphyloma or from axial length myopia. So now you're thinking okay, why is this 24 and a minus 18? Now it goes back either to the cornea or the lens. So
yeah, that's an excellent addition, Greg. So dealing with this patient, ultimately prescribed some medicines at that time because he was chronic angle closure. His pressure came down, did open up a little bit. Ultimately, he had to go with laser iridotomy. It did open both angles, but he had residual synechia. He did need multiple medications. He was ultimately controlled on a prostaglandin, a beta blocker, an alpha-2 adrenergic agonist that got him down to a reasonable level. Now, he had a very, very complicated course. You may just ask, well, if this lens is causing all that myopia and this lens is causing that glaucoma, just take it out. Well, there are a lot of complications for these little small lenses, including choroidal and retinal detachment. So there are a lot of complications, and most cataract surgeons don't want to really get involved in something like this. And medically speaking, he actually did fairly well. Now, one of the kind of challenge, and Stephen points out this is a very complicated cataract extraction. Will they suture the IOL? The answer is most likely yes. Ultimately, I will tell you, he had a very complicated course. The glaucoma was controlled after in a relatively expeditious fashion with LPI and some medicines. But over time, and even though he was very young, he does have a very funky lens. He developed visually significant cataracts, one eye than the other. He had cataract extraction. He developed cystoid macular edema. He developed a MRSA infection. He actually had a dislocation of the lens, which had to be repositioned. And of course, he's got really, really very, very constricted visual fields. And he developed a bromonidine allergy. And when he was getting his cataract surgery, the cataract surgeons at the facility stopped his glaucoma medicines because he was having allergic reactions to them, and that didn't do anything very good for this fellow. Ultimately, I still know him. He still keeps in contact with me for my old practice. He is currently 20 happy and doing really very well.
Yeah, my comment on that case, Joe, for Stephen's comment, sutured IOL. The cases that I've seen like this, maybe 2 in my lifetime, and similar kind of, lens-induced type of glaucomas, they were done by retinologists where they went and did through the pars plana, phacoed the lens out, removed the lens, because you're not leaving the capsule behind in this sense. in taking out the whole lens. And even if the surgeon would do that, they might lose the lens to the vitreous and it still needs a vitrectomy. So the cases I've seen were we're done, not kind of, we're done by retinologists that removed the lens and then sutured the IOL in place in these cases, because it was a more complex, the little thoughts for that one to the audience and for Stephen.
So the moral of that story is, yes, even high myopes can undergo angle closure, but it's not your typical pupil block. Always think microspherophakia. Well, here's a case that just isn't clear. 24-year-old female complains of blurred vision, left eye, happening twice a year since age 7. It would go for a couple days at a time and spontaneously resolve. She never actually went for medical care. This is the first time. And I will say, I think this is a very impressive history. This young woman can relate this to me. He's 2015 right eye, 2020 left. There's no afferent defect. Pupils are normal. Confrontation fields are normal. Medical history unremarkable. And I actually meet this patient when I'm supervising students and residents at Nova. And a student and resident showed up on my doorstep presenting this case, and they've been refracting the heck out of her for about 30 minutes. And she keeps vacillating between +1/4 and +1/2 in the left eye, and she keeps just telling them it isn't clear. So when they give me this history of recurrent blurred vision for many years, I had something that went through my head. It was my Dr. House moment. I didn't tell them why, but I just sent them back and said, please go look at the anterior chamber of this patient and tell me what you see. And they scurried off and they're gone so long, I forget that they're there. And after about 25 minutes, they come back and they tell me they can't judge the anterior chamber because the cornea is too cloudy. At this point, I decided I'm going to get involved. Her conjunctiva was clear, but she did have some corneal edema with a few chorotic precipitates. Her anterior chamber was deep. Her pressure was 21 in the right eye and 70 in the left. And she looked like, this was not her, this is a representative patient with a few centrally located chorotic precipitates. She had a bit of corneal edema, and her pressure was 70. So what is your diagnosis and treatment? I guess we can put that in the chat room. What do you think, everybody? Anybody want to put anything in the chat? She's got a few chorotic precipitates. She's otherwise minimally symptomatic and a pressure of 70. I know people are thinking, John says glaucomas occlusive crisis. Stephen says herpetic. Glaucomas occlusive crisis. Uveitic glaucoma. UGG. UGG, the tight chafing underwear glaucoma. Uveitic. All right, excellent. I like everybody's thoughts. Fuchs or glaucomas occlusive crisis from Brooke. Very good. Julie, hi Julie, it's good to see you again. GCC, excellent. All right.
So let me comment on UGG, which is usually uveitis, glaucoma, and hyphema. There wouldn't, that's kind of for the patient that has cataract surgery. There wasn't any reported cataract surgery, right, Joe?
Correct.
So UGG syndrome, uveitis, glaucoma, hyphema, UGH. That's usually whenever they use an anterior chamber IOL. And when they do an anterior chamber IOL, they're supposed to put the haptics, if it's not pupil fixed, if it's going into the angle, they're supposed to put the haptics onto the scleral spur. But that's kind of hard to land those haptics onto the scleral spur. And sometimes they do poke through the trabecular meshwork. Now you're irritating the trabecular meshwork, the ciliary body. So hence the uveitis, the glaucoma because of the inflammation, and because it's vascularized, you can get the hyphema. So that's usually what UGG syndrome is for. I think if that's where that doc was going for. If not, then you got a little extra bonus out of me talking about that.
Yes, I like to refer to UGG syndrome as a tight chafing underwear of glaucoma. All right, so this is a patient who has got glaucoma cyclitic crisis. And, we're going to address this in terms of the anti-inflammatory. It is a uveitic ocular hypertensive syndrome that is idiopathic and idiosyncratic. Now, what do we do? I very rarely ever even consider lowering pressure in the office. I actually did this more as an educational demonstration for the students and residents. And in office, they use a steroid, a beta blocker, an alpha, and a carbonic anhydrase inhibitor. After about 30 minutes, the pressure dropped to 50. At a pressure of 50, the edema was completely gone. Her vision went to 20/15. Everything is perfect. Can I go now? I give her a few more drops. She drops down to 35. I release her. She comes back as requested next day. Her pressure is 10. And complete glaucoma evaluation was perfectly normal in each eye. So in dealing with glaucoma cyclitic crisis, steroids are going to be required. It's the most important medicine. In fact, steroids alone will work. It is self-limiting. Aqueous suppressants, alpha adrenergic agonists, carbonic anhydrase inhibitors can all be used. Oral osmotics are typically not necessary. I would say probably avoid miotics or prostaglandin analogs. Miotics can probably increase the inflammation a little bit. Prostaglandin analogs probably aren't going to hurt the patient very much, or probably won't hurt the patient at all, but may not be very, very helpful. Always consider this in an unexplained unilateral pressure rise. Look for any cells, any flare, any correct precipitates, especially at the follow-up. Sometimes it's not really all that apparent. Now, points to ponder: is this a truly benign disease? Now, this is a young woman who has had this happening numerous times for many years, and she was perfectly normal. I had heard GCC is a benign disease. It is self-limiting. Don't underestimate it. I have had probably 50% of the patients that I've seen with glaucoma cyclitic crisis have developed glaucomatous damage. If their pressures are elevating repeatedly, they will develop damage. Is this a real diagnosis or a variant of uveitic glaucoma? I think it is its own distinct diagnosis, but I do believe it is a viral disease. It is probably a herpetic variant. Glaucoma cyclitic crisis is idiopathic and idiosyncratic. Idiopathic is we don't really have a demonstrable pathophysiology. It is theorized to be an acute trabeculitis, that the inflammation is limited to the trabecular meshwork because there is just not much inflammation going on. That being said, nobody's done a biopsy of these patients during an acute crisis. We don't know. That is only a speculation. It is recurrent. It is unilateral. It is self-limiting. For that reason, it is a lot like a virus. It smells and acts like a virus. It really does behave a lot like herpes. And there is a distinct entity called herpetic keratouveitis, where a patient with herpes simplex, typically, or even zoster, can have a mild degree of inflammation with a secondary pressure rise that may not be proportionate to the low amount of inflammation. The difference between the two diseases is that in herpetic keratouveitis, the pressure elevation tends not to be as dramatic, and the inflammation tends to be a little bit heavier. But I do think they're probably different ends of the spectrum of the same disease process. Now, they have found herpes virus and cytomegalovirus in the anterior chamber of patients with glaucoma cyclitic crisis. That being said, they've also found patients with glaucoma cyclitic crisis with no viral antigens in their anterior chamber, so we just don't know. But it is most likely a herpetic variant. It is actually reasonably common. It is self-limiting, it is unilateral, it is recurrent. It does tend to burn itself out over time as the patient ages, and it is not a completely benign disease. I've seen patients lose vision from this condition. Now, here's a patient. This is a patient whose pressure is 14 in each eye.
Joe, are you moving on to another case?
Kind of.
Okay, because I do have some comments whenever you do get through the glaucoma cyclitic crisis, but go ahead, please.
No, you can go right ahead. No, no, you can do it right now if you'd like, Greg.
Okay, so regarding the glaucoma cyclitic crisis, the comments that I would make would be when you're looking for those KPs, they're not going to be mud and fat and obvious and numerous as if you would see in a bad uveitis. It might just be one or two little pinpoint where you're like, is there really something on the endothelium or not? And they are KPs. So it's almost like that KPs that, after you treated a uveitis and it's almost gone and you see one or two. So it's not going to be like an obvious. So look carefully for the KPs. As Joe mentioned, the steroid is extremely important in this. A lot of times what I'll do is if I have a bottle of, Combigan in the office, we do keep some meds in cabinet. I literally just give them the drop to use, tell them to use it 3 or 4 times a day. People will say, well, that drop's only twice a day drop. And I'll say, well, if you put it in both eyes, 2 times 2 is 4. If I'm only using it in one eye, I can use it 3 or 4 times a day. It's the same amount getting into the body. So I use that from time to time, but it's the steroid. One of the questions I like to ask is, do you suffer from steroids? Because I do believe that there's some type of viral component here. And I think what has happened is that the body has detected the herpes virus, has killed the herpes virus, and now we have protein that is from the herpes virus that now has overcome. Remember, the anterior chamber has immune privilege. The eye, inside the eye has immune privilege. It should not react to something unless there's a foreign material in there. And so I think that foreign material is the dead carcass of the bug, and the body's reacting to it. So the body has eliminated the active the virus, and then you're just seeing kind of the body's reaction because the immune system killed it, but now you have dead protein. So as for cold sores, there's usually a high. I don't know, I have probably in the course of my lifetime have 12 to 15 patients, and probably 80 to 90% of them have a history of cold sores.
Now, Peter's asking, could Lyme disease play a role in this? Peter, I don't think so. I mean, Lyme disease can cause a uveitis. A uveitis can cause a secondary pressure rise, but it's not really been associated with GCC. The ones that have been associated have been cytomegalovirus and herpes virus. Now, I do get asked, a question: what do you do during the quiescent period? Do you always treat the patient? The answer is no. But what I have taken to doing in patients like this, and it's with informed consent, is I explain the issue of viral antigens and the possibility of it being herpetic. And I will actually prescribe a suppressing dose of valcyclovir, a gram a day, or 800 or 400 milligrams of acyclovir or valcyclovir a day as a suppressant. And what I have found in my unpublished, unscientific experiences, it did seem to reduce the outbreaks. Now, here's an interesting patient.
If you go with a maintenance dose, please make sure you get those kidney function tests done on those patients. The Valtrex, acyclovir, Famvir are all cleared through the kidneys. So make sure you're working with the internist on that. I certainly agree that's the way to go, but don't forget to notify you're one part of the team here. Make sure you're getting kidney function tests done, especially if you're going 500 to 1,000 of Valtrex or 400 milligrams twice a day on that.
When we take a look at this patient, and this will be one of the challenging ones that come in. He has got a strictly unilateral glaucoma. You can see he's got a notched neuroretinal rim, inferior defects, a symmetrical pressure of 14. And this will be a challenging patient, and you wonder, why is it so asymmetric? And is this asymmetric normal tension glaucoma? The answer is no. When you look at his pressure history, he actually has recurrent glaucoma cyclitic crisis. And most of the time, his pressure is good, but you can see that there are periods where he does go up into the 50s, and it did cause glaucomatous damage. He probably had about 20 outbreaks that he actually kept track of himself. And after a period of time, it actually ceased happening. Well, what I think is fascinating about these patients is they're very stereotypical. When their pressure spikes, it usually spikes to the same level or very, very close. It's not like it's 32 on one attack, and then the next time it happens, it's 58, and the next time it happens, it's 37. You can see if he goes to 50, it goes to 50 virtually every time.
And that's a good comment there, Joe, to make kind of out that these patients, they go from, 0 to 100 in, 30 seconds. They go from, in this case, 18 to 50. So that means they're going to swell. Their cornea, their vision's going to drop. So, that's why I don't have a problem. These patients become symptomatic. They know to come in, they know to get their pressure checked. But also you got to be careful, because if you give them a big bottle of steroids, they'll just start treating themselves, which can get themselves into problem. But that's is the reason why you can get away with monitoring these patients and not have to do maintenance, because when they do sweat, when their pressure goes up, it goes up rapidly and it creates that cornea swelling. And then Michael put in the question, how often should they have their kidney function test while on a maintenance dose? That's a great question, Michael, to work with the primary care doc. I do a lot of maintenance dose, and just like we don't like to be told like how to monitor something, what I like to do is just tell the primary care doc, I say, listen, this patient here is going to put them on a maintenance dose of 500 milligrams. They're probably going to be on it for at least a year or two. Who knows how long? It is cleared through the kidneys. Can you please follow them how you feel is appropriate with the kidney function test? But that definitely make sure it's done yearly. If not 6 to 12 months, I ask the question. I just don't tell the PCP or the internist and or the PA or the nurse practitioner how to do it. So we just kind of leave it up to them. Just make sure it's getting done. That's a great question.
Excellent. Well, here's a patient, 59-year-old female, longstanding decreased acuity in the right eye, 2200, 2400. And, she had corneal and chorioretinal scarring secondary to a childhood rubella infection. And, during examination, her fundus details were very observable. She had a worse cataract in the right eye compared to the left. The pressure was about 10. So the patient referred out for a surgical consultation. At that time, vision was 2400, 2050. Cataract surgery was not recommended due to pre-existing ocular damage. Didn't think there was a good candidate. Fundus details were pretty visible. About 17 days later, after her ophthalmology consult, the patient develops a painful right eye following several days of progressive vision loss. And that's why I was asked to see the patient urgently. Patient comes in. Now is light perception right eye. There's an anterior chamber reaction, and pressure is now double what it was. And the patient looks like this and had a very, very hypermature cataract that was now actually beginning to leak and initiating this antigen antibody reaction, and she actually went phacolytic. And phacolysis is probably the second most common lens-induced glaucoma. This is a elevated intraocular pressure associated with a very hypermature cataract. The vision is going to be in the light perception range. It's a very, very, very poor vision. There's going to be a visible anterior chamber reaction. Could be some flare. Hypopyon, very, very, very atypical. these are patients we're going to temporize the IOP and temporize the inflammation. And ultimately, what we want to do is get that lens out. But what I want to stress to you is the fact that hypermature lenses can actually begin leaking very quickly. This is a person who had a sudden deterioration over the course of about 3 weeks and ended up being phacolytic. So ultimately, the lens was taken out for a medical reason. She actually did quite well. She ended up like a 20/40 visual acuity. Any comments or questions, Greg?
No, comments are that's the antigen that's creating the inflammation in the eye, and removing the lens is the treatment. So
if possible, sometimes there's poor visual potential, and we may just treat the patient with steroid and cycloplegics ad infinitum. Well,
and I'll make a comment on some of these hypermature lenses that aren't leaking. The key is know your surgeons in the area. We talked about, that kind of microspheric lens. You got to get to a maybe to a retinologist to do kind of a posterior lensectomy. And these hypermature lenses that aren't leaking, that's not something for your, for your new cataract surgeon. You'll see them use sometimes Typam blue, where they'll take and stain the surface of the cornea. As we know, capsulorhexis is really the key to cataract surgery, making that capsulorhexis, phacoing out, putting the lens in. These hypermature lenses, as soon as they tear that capsule, it's a big fog. They can't see where they're tearing to make that capsulorhexis. So one of the tricks that they'll do is they'll stain that front surface with Typam blue. So you're kind of coaching that patient. You kind of have to know these things whenever you're making that referral. There's a couple patients that have come in my area that have had that, and I've actually sent them, say, look, you have to cross the mountain. You have to travel over to see this doc because he'll stain that capsule and it's trying to give you the best outcome. So that's really not when it's not leaking, but just remember, as soon as they tear that open, that lens is liquefied, and it's just hard for the surgeon to see. So just a little FYI and a little comment on that.
And here's what will probably be our last case of the evening. 21-year-old female who was referred to me for elevated intraocular pressure, but she didn't have any sort of referral note or information. She just knew that's what she was sent for. She complained of snowy vision of the last few months that was getting worse. Her ocular history is unremarkable. Family history is unremarkable. Medical history, she had been diagnosed with asthma in 2017 and had no medical allergies. So really, she is complaining of snowy vision, and she is referred for elevated pressures, though I didn't have any other information. Now, she's pinholing down only to 20/40 in each eye. There's no afferent defect. Cornea was clear in each eye. The irises were black, or brown and flat, chamber deep and quiet. Goniostomy, open to ciliary body, no abnormalities. Pachymetry thick at about a 640, but her pressure was markedly elevated at 72 in each eye. And she looks like this. And as you take a look, we can certainly see that there's some thinning of the inferior neuroretinal rim in each eye. There's a relatively good sheen of nerve fiber layer superiorly, but there is a lot more choroidal detail that you can see inferiorly, and this represents a pretty diffuse atrophy of the nerve fiber layer inferiorly, corresponding to the thin rim tissue. And we can see it's probably even a little bit better here on the red frieze. In terms of her OCT, nerve fiber layer and ganglion cell complex, you can see that there are some abnormalities in the nerve fiber layer inferiorly. There are some abnormalities again in the ganglion cell complex inferiorly, matching our clinical appearance, and quite an elevated pressure of 72. And this comes with a pretty significant visual field defect. So taking a look at her, she's 21 years old. She's best corrected at 20/40 in each eye. Thick corneas, pressure markedly elevated at 72 in each eye. We see her fundus, we see her structural measurements, and we see her visual fields. So what are your thoughts here? You can just put this in the chat room. What are we dealing with here? Let everybody think about this for a second. Show you again, very high pressure, 72, young person, reduced acuity, abnormalities in the nerve fiber layer, both clinically and OCT, and subsequent visual field loss. I hear a juvenile open angle glaucoma. Anything else? Actually, a very, very good thought, Brooke. You know, that's an excellent thought. Could be juvenile. Julie says it's a steroid responder. Okay. Well, let's move on. Examining her, she had about a 2+ posterior subcapsular cataract, which explained that snowy vision. And when I saw that, I knew our diagnosis was pretty obvious. Her pressure was 72. You know, I asked her, how's that asthma being treated? And she admitted that she was self-medicating with dexamethasone injections 2 to 3 times per week that she was getting shipped to her out of Honduras. Now, things that I saw that you don't have the access to, but I'll show you. And these are just representative examples. This is not the patient. She had that round moon face. She had thinning hair. She had the adipose tissue in the back, the buffalo hump. And essentially, it was a steroid-induced glaucoma from self-medicating.
She giving herself an intravitreal injection?
Pardon me?
Does she do an intravitreal injection too, the administration?
Yeah, no, it was just IM.
Yeah.
So she ended up looking like, looking like this. And when I saw her appearance and her countenance, I saw the PSC cataracts. That's when we go in the history about asthma. I using steroids. Yeah, I get it out of Honduras. It's the only thing that really seems to help me. And she's been injecting herself, several times a week. So she basically was essentially killing herself. And this is one of those situations where we've got a steroid-induced glaucoma, but I can't really get her off of the medicines very easily. But we can't stop it. You know, her adrenal cortical axis has shut down. She'll become hypopituitary and hypopituitarism. She could die from this. So this is one of those situations I actually had to get her right off to an endocrinologist who, interestingly, put her on steroids. Now, the reason they put her on steroids is they stopped the intramuscular injection, but put her on oral steroids to wean her down and get her off. And of course, she had induced diabetes. So she had given herself an iatrogenic Cushing syndrome along with diabetes, cataract, and fairly advanced glaucoma. Greg, any questions? Any comments about this? What are your thoughts and experience with steroid glaucomas?
Yeah, I mean, my comment was going to be just to echo what you said there. You're going to say to this girl, you created cataracts, you got glaucoma, you have damage, here's your visual fields. And right off the bat, she's gonna, I'll just stop that immediately. And that's a coaching that you got to be careful with. Basically her whole hormonal symphony, if you want to call it, she's got, as you said, an insulin, a glaucoma. So that part of the hormonal is the cortical, the adrenal glands, maybe some thyroid that's connected, her sex hormones, that whole adrenal, that whole hormonal symphony is just out of whack. So you just have to, out of kilter, you just got to be careful with that, with this patient here. It's a great case. It's just that you don't want to scare them to where I'm going to stop it, because you see the doc did put them on orals.
Yeah, so this is one of those rare situations where glaucoma can act, or technically the whole condition can be fatal. This was a very bad self-induced case. Greg, rather than trying to rush through anything else, I would say I think we're going to start to land this one. Greg, do you have any comments about any of these atypical or challenging patients or challenging glaucomas that you want to share with the audience before we start wrapping this up?
No, well, I'll make a comment. I just want to echo that, you did a great job on these, on these cases, these challenging glaucomas, challenging patients, a lot of them were young. My comment is a lot of them were young, and that's kind of, glaucoma, primary open-angle glaucoma, maybe in a Black population or Asian population, 40s, white population, 50s, kind of as the early onset. And you had, as I was going through here, watching your cases, 37s and, 21s and so on and so forth. So they're kind of those kind of secondary, lens, steroid induced, type of glaucoma. So watch that age out there. And then you started off with the juvenile glaucomas, not to say that, that there can't be, those types of glaucomas, but, watch that age. And when you have the age, start scratching your head that it's something else going on. And now it's that something else that you gotta, ask around. And just had a PSC come in the other day, and just, I said to the patient, how long were you on steroids? And they're like, how'd you know that? And, this PSC cataract. So, those are my comments. Again, you did a great job of presenting these challenging cases. So.
And Tom says, never estimate a person's propensity to do the wrong thing. Yeah, absolutely. So before we kind of wrap it up, with a ton of things we could have gone through. Maybe we got another lecture in here somewhere, Greg. We can just wrap this up sometime later. I just want to just skip to the end and say, that's all, folks. This is the end for us for 2022. Have happy holidays, Merry Christmas, Happy New Year's, all happy holidays. And we're looking forward to seeing you next year. I think I've got the privilege of starting off 2023. So Greg has allowed me to end 2022 and will allow me to do 2023 to start off with. So we're looking forward to coming back with some interesting education for you all.